A critically ill patient in the intensive care unit is lying in bed, fully mechanically ventilated. The standard bedside monitors show a steady heart rate and a normal baseline blood pressure. Then, the blood pressure suddenly drops. The patient is crashing, and the baseline numbers you were relying on failed to predict it. The core limitation in standard critical care monitoring is a reliance on surrogate pressure metrics. Take central venous pressure, or CVP. It measures the pressure in the great veins returning to the heart, but it only shows pressure. It does not measure the actual physical volume of blood moving through the cardiovascular system. When that hypotensive patient crashes, the intensivist faces an immediate therapeutic conflict. Does this patient need a fluid bolus to increase blood volume? Do they need vasopressors to clamp down the blood vessels? Or do they require inotropes to help the heart muscle pump harder? Making the wrong choice here carries immediate consequences. Administering fluids to a patient whose heart is already failing to pump their existing blood volume can cause catastrophic fluid backup into the lungs. Surviving the ICU's complex physiology requires a system that abandons these misleading pressure surrogates. We have to measure true volumes and real-time cardiac dynamics. This is where the PiCCO system operates. It functions as a dual-technology hemodynamic engine designed to quantify exactly what the heart and vessels are doing. To build this complete picture, the system combines two specific physical principles: transpulmonary thermodilution and arterial pulse contour analysis. This flowchart is the ultimate output of those combined physics. It is a streamlined, unified clinical algorithm that translates raw data into distinct therapeutic pathways. We will deconstruct this matrix, node by node, to understand exactly how it dictates patient resuscitation. By learning to read this decision tree, the chaotic guesswork of severe shock states is replaced by a solvable, protocolized equation. Looking at the top node of the algorithm, we start with the cardiac index, or CI. Before we can treat the patient, we must first determine if their global systemic blood flow is adequate for their body size. To acquire this baseline flow metric, the system relies on transpulmonary thermodilution. This schematic shows the procedure. A clinician injects a precise saline bolus into a central venous catheter. The bolus travels through the right heart, lungs, left heart, and is pushed into the arterial system, reaching a specialized catheter in the femoral artery. This graph displays the data. The arterial catheter detects the temperature drop, generating this specific curve. By calculating the total area under this curve, the system derives the intermittent cardiac output, indexing it to body size to give our starting CI value. This single cold bolus roots our entire clinical assessment in undeniable, measured physical flow, entirely bypassing the pitfalls of estimated pressure. Moving down to the second tier of the decision tree, if that initial cardiac index is low, we must determine why. The first question to answer is whether the heart is underfilled. Standard CVP measurements fail here. Because CVP is a pressure reading in the chest, it is easily artificially elevated if the patient has stiff lungs or is receiving positive pressure from a mechanical ventilator. To solve this, the algorithm introduces the Global End Diastolic Volume Index, or GEDI. GEDI measures the actual physical volume of blood contained within all four chambers of the heart at the exact moment right before contraction. Clinical studies establish that the optimal target range for GEDI is between 680 and 800 milliliters per square meter. This physical volume connects directly to myocardial pre-stretching. The greater the volume of blood filling the chambers, the more the heart muscle fibers are stretched, which dictates the force of the subsequent pump. Looking at this Frank-Starling curve, we see how this volume measurement is applied. If the patient's GEDI places them on the steep portion, Zone B, they are volume responsive. If they are on the flat portion, giving more fluid only causes volume overload. By quantifying true internal volume instead of external pressure, GEDI definitively answers the critical question of whether the patient actually needs fluids. Transpulmonary thermodilution establishes an accurate baseline, but it has a significant flaw. It is static. It only updates when a clinician physically injects a cold bolus. The physiology of a patient in septic or cardiogenic shock changes second by second. The intensivist requires a continuous flow of real-time data. To achieve this, the system shifts to its second principle, arterial pulse contour analysis, which provides real-time beat-to-beat hemodynamic monitoring. This continuous arterial pressure waveform contains a wealth of data. The system analyzes the shape of this wave, using the thermodilution measurement as calibration. Specifically, the shaded area under the systolic portion directly reflects the blood volume ejected with every single heartbeat. These two charts illustrate how the shape of the wave reveals cardiac muscle performance. The steepness of the initial upward slope, calculated as dP max, measures the left ventricular contractility. A steeper curve means a stronger, faster contraction. This continuous beat-to-beat analysis also unlocks dynamic fluid metrics, most notably stroke volume variation, or SVV. SVV tracks exactly how much the stroke volume fluctuates in response to the changing intrathoracic pressure of each mechanical breath. If the variation is high, the heart is highly dependent on preload, serving as another hyper-accurate predictor that the patient needs fluid. Pulse contour analysis takes the highly accurate static snapshots of thermodilution and turns them into a continuous, real-time movie of a failing cardiovascular system. But fluid resuscitation carries a primary inherent danger. If we push volume into the vessels and the hydrostatic pressure becomes too great, or the capillary walls become too permeable, that fluid leaks out of the bloodstream and floods the interstitium of the lungs. This brings us to the final critical node on the decision tree: lung water. Standard ICU practice relies heavily on chest X-rays, like this one, to spot fluid accumulating in the lungs. But X-rays are notoriously late indicators. By the time enough fluid has accumulated to produce this severe bilateral whiteout, the patient's ability to exchange oxygen has already been dangerously compromised. To catch this accumulation before it causes respiratory failure, the algorithm relies on an early warning system, the Extravascular Lung Water Index, or ELWI. As this graphic details, ELWI is calculated mathematically. The system subtracts the intravascular blood volume from the total intrathoracic thermal volume. The remainder is the amount of fluid sitting outside the blood vessels in the lung tissue. This formula quantifies exact fluid leakage directly at the bedside, alerting clinicians to pulmonary edema long before it becomes visible on a chest X-ray. The algorithm sets a hard clinical limit. If the LWI value exceeds 10 milliliters per kilogram, fluid administration must halt immediately. ELWI acts as the ultimate physiological safety brake, preventing clinicians from inadvertently drowning their patients in the quest to restore blood pressure. We now possess the three critical variables: global systemic flow, cardiac preload volume, and extravascular lung water. Looking back at the complete PiCCO matrix, we can see exactly how these measurements synthesize into definitive clinical action. Following the path on the far left, we have a patient with low flow, an underfilled heart, and dry lungs. The definitive intervention for this specific hemodynamic profile is volume loading. The patient requires fluid, and their lungs are dry enough to handle it safely. But compare that to the middle pathway, a patient with low flow, an overfilled heart, and dangerously rising lung water. This heart is failing on the flat portion of the Starling curve. Pushing fluids here would be lethal. For this profile, the algorithm mandates inotropes to strengthen the heartbeat and volume withdrawal to clear the lungs. Monitors do not cure patients on their own, but they illuminate the dark, rapidly shifting terrain of clinical shock. By translating complex transpulmonary physics into measurable, real-time metrics, this system replaces deadly clinical guesswork with algorithmic precision.